So on my podcast, by popular demand, is my husband, Paul Anderson, who is a consultant urologist for the NHS. He's a reconstructive surgeon, has done thousands upon thousands of operations, transformed men's lives. So we talk about his work, not my work for a change. We talk about the impact of hormonal changes had on me and our family. We talk about conversations with nurses. We talk about how we can help demystify hormones and maybe help healthcare professionals think differently about hormones too. So we cover a lot, and it's just lovely having him here with me. Paul, you're here in real life. Very excited that you're here with me. 2021 apparently was the last time that you came on my podcast, but you were downstairs and I was upstairs.
It was much more low tech.
And now, yes.
Well, you've progressed, developed. You're even more famous, infamous. It's fantastic.
It is good because actually some of the nurses what do they refer you as in the hospital, Paul?
Well, I should probably change my name to Mr. Newson, because people I've known for years, decades, will come up to say, "Oh my God, you were Louise Newson's husband."
You like that, don't you?
Right. I've got used to it.
So I want to just shine the light onto you, actually, because lots of people know who I am. They know exactly what I do, but they don't know so much about you.
That's where I like it.
I want to shine light on you because you're really, I don't know how you measure success, but you're a very inspirational surgeon. You're top of the game what you do. You're more modest than me, probably, but I just think what you do is incredible, but people don't know about it. And actually, compared to even what you were doing 4 or 5 years ago, it's got even better. And I'm telling you this because I was at a conference recently in Perth, a urology conference, and you were a bit annoyed because you were at the same conference last year and you are a urologist and I am clearly not, but I was invited to talk. And the more drunk your colleagues got, the more they told me how amazing you are and what a fantastic surgeon you are. And they've never seen anyone operate like you do. So it's not because you've told me you're good, it's because others have. But just explain a bit about what you do, because some people might not know what a urologist is, but they probably don't know what a genitourinary reconstructive urologist does.
So urology is the branch of medicine that deals with surgical problems, as in things that can be solved through surgery, not through drugs, that affect the kidney, the tube that drains the kidney, the ureter, the bladder, and the urethra, which is the water pipe. And within that field, there are people that deal with, say, cancer, people that deal with kidney stones, and I specialise in reconstruction of the male genitourethral organs. So I spend most of my time fixing water pipes, urethras. I do a lot of time with the penis. You know, sometimes it's bent through Peyronie's disease, and certainly I did all those for embarrassing bodies. And I deal more commonly, you know, these days people are getting bigger, so I deal with buried penises. I also deal with rarities like people have injected silicone into the genitalia, removing it, skin grafting the
penis. Hang on a minute. Injecting silicone into the genitalia, is that a thing?
Yeah, totally. It's pretty popular. It makes your scrotum look larger. It can make the shaft look bigger. I do not recommend it. I do not condone it. But lots of people do it, and I just see that people have complications with it to remove that silicone. That's a very small amount of my job. It's mainly water pipes.
Yeah. What's the biggest myth about male genital health that drives you mad?
That having a longer penis is going to improve your life.
So it doesn't?
I see so many patients who blame the length of their penis for their current state of unhappiness. You know, whether it's body dysmorphophobia, you know, they're coming to me because they wanted me to do an operation to make the penis longer, and actually it's just a symptom of not being happy. And actually making the penis longer. So surgery can give you about an extra inch, but I would not recommend it. You know, it does nothing really.
So people who have injuries as well, when the urethra has been damaged, then they can't wee. I know this sounds really obvious to you, but to many of us it's hard to get our heads around. They can't wee out of their penis, so they have a catheter, don't they, often? That goes
so, I mean,
bladder.
It depends in which country you're talking about, because you know, in the previous podcast we discussed my work in low and middle income countries. So in a low and middle income country, such as the ones I go to in Africa, they would just have a catheter, a tube that goes straight through their stomach into their bladder, and that will be the end of it. Whereas in the developed country, they will have stretches, dilations, cuts, to keep their water pipe open until someone does a reconstruction. And that's the sort of thing which I particularly specialise in. And it could be people who are in car crashes and they have a fracture of their pelvis and their water pipe is ripped off their bladder, so there's no communication. It can be people who have had injuries during other urological operations, such as for their prostate, where the water pipe gets damaged. It can be people who are born without a water pipe that goes all the way to the tip of their penis, like hypospadias. So the water pipe opens in the wrong place, further down the penis, and they need that reconstructing.
And how do you make a new water pipe?
We predominantly use the inside of the mouth, because the inside of the mouth can cope with being wet all the time. Other parts of your skin, can't. If you spend too long in the swimming pool or the bath, your skin gets macerated. You get like Christmas trees at the end of your finger, so it can't cope with being wet, especially with urine all the time. So it's mainly the inside of the mouth.
So you do a graft from the inside of the mouth, and then put
it into the water pipe just to make it wider. So that's an augmentation, adding to what's there. But sometimes with, say, a pelvic fracture, I have to join the two ends together, no mouth graft. And that can involve using, a hammer and chisel to take out big pieces of bone, to reroute the water pipe, to attach it back onto the bladder so that they can wee properly. And I spend a lot of time teaching those techniques in Africa, because over there, they don't have airbags, they don't have good scaffolding, they don't have health and safety at work. They're falling down wells, they're being kicked by donkeys, they're coming off their mopeds. If they survive the head injury, they've got a pelvic fracture. And there's lots of young men who have a catheter through their tummy, who have got financial catastrophe. They might be responsible for making money for a family of 15. If they're 22, 25 years old and they can't work, that is a big problem.
Because they can't work when they've got a catheter in.
Well, especially poorly maintained catheters in a hot country, when you get to the bladder stones, urinary infections, some people go on to kidney failure.
But also there's a stigma, isn't there, for people who have an indwelling catheter in some communities.
Definitely.
Because I remember, you've been going back and forth to Africa for many years, and I remember one time there was somebody who walked from an orphanage for about an hour just to be assessed by you, and you can't operate on everyone, but you chose this person, and he wrote to you, didn't he, afterwards?
Yeah, so, an hour is not bad. Some of them travelling for 3 days. I'm going to places where there may only be one urologist serving, 40 million people. It's crazy. But this particular gentleman was in an orphanage, and then when he came back, the owners of the orphanage, who were running it, got in touch with the surgeon who'd been training over there and sent a video saying how grateful he was and how it changed his life.
And other people's around him as well.
Yeah, totally.
Yeah. And you've also done quite a lot of work with military in the past as well, which I remember the first time you came back from operating on a soldier, I've never seen you so white. I've never seen you so quiet. And it was quite shocking. Do you remember we were in the old house?
Yeah, well, that was sort of 2008, 2011, Operation Helmand. And this is really before the pelvic protection got going. So when these servicemen stepped on improvised explosive devices, they would lose their legs, they'd get their rectum blown apart, they'd lose their genitalia. Fortunately, that period of time was only about 18 months, maximum 2 years before the pelvic protection came in, and then they just lost their legs. That sounds terrible, just lost their legs. But they hadn't got the same injuries to the genitalia and the rectum. And so there was a large cohort of men coming back to the Queen Elizabeth Hospital in Birmingham, which is the major military hospital which I work nearby and have a contract with. But to see a 19-year-old who was so devastated, to see these young men with injuries that were, so severe that they wouldn't have survived in times gone by, was emotionally very difficult, and I'm just the person who was treating them. I'm not living with that injury. But it got easier to see past that and what I could do for them, as time went by.
But you really did transform the quality of their lives.
Yes, I'd like to think so. I'd like to believe so.
You did, because I've heard them talk about it. So.
Well, GQ did an article, May 2000, whenever it was, talking all about the soldiers and interviewing them.
But I, as you know, when I had that hysterectomy, I had bladder problems and I had a catheter in. In fact, I wore your pyjamas for a few weeks because then I could have the catheter bag out. It was the most undignified thing I had. It was horrible having a catheter. I thought everyone could smell me. I thought everyone could see it, even just, having the leg bag and wearing a floaty skirt just at night time. It's horrid. And I don't know, there's something about urine I don't really like. But I realised then, like, how we just take having a wee for granted. And like, I can't imagine some of the patients you see, the stories that you tell me, that how it's gone on for so long. And like, I like to think the work I do is transformational, but your work is really transformational in a different way.
Well, one of the things that attracted me to urology in the early days, before I decided to be a urologist, was how much you can improve the quality of older men just by performing fairly straightforward prostate surgery so that they could pee on demand and not be incontinent. And that is absolutely transformational, to not be incontinent. And I've carried on in that vein. And, you know, I strongly believe that people should come forward with their incontinence problems, not just suffer with pads.
Yeah.
Because somewhere out there will be someone who can help you.
You know, urinary incontinence in women is really common. Recurrent urinary tract infections are really common. How much do you remember being taught about hormones at medical school?
Very little.
Yeah, I mean, we did train together.
Very little.
So you did spend some of the lectures more hungover than me, so I'm not quite sure how much you learnt. But your notes were always very good. You still have this really annoying skill of remembering everything.
I have a photographic memory.
I know you have a photographic memory. Because you also don't like throwing things away, do you, darling? So we've got like your old lecture notes, and every so often they sort of fade because you were, I don't know, not listening properly. And I thought, good, my notes are going to be better. And I had my highlighter and I had my coloured pens, and you sometimes draw a little mouse on my notes. And I thought, you're not concentrating. And then you did really well and got distinction in the exams. And you just remember everything, don't you? But isn't it interesting that you remember that we weren't taught about hormones at medical school? And I don't think it's really improved. You know, the junior doctors that come through, are they talking to you about hormones in respect to urinary incontinence in women?
No, not at all.
What do you think of that?
Well, I think we should all be thinking about it a bit more. I think about it more because of you, and I've proofread so much of your work over the years. So even if I see, when I do my week on call, and I see children, I see women, I see men, you know, if I see a lady who's got a fragility fracture, I'm often saying to them, why aren't you on HRT? Who's thinking about your bone density? You know, it's not just about HRT to improve the urinary health, but it's just about general health. And so you've educated me, and I've read around it a bit. And it's also there in the European Association of Urology guidelines, that we should always be considering HRT, or at least topical estrogen to the introitus, vagina, for infections. So we are thinking about it more, and it gets more coverage in our conferences. And of course, you've been to those conferences and lectured on it yourself. I know.
I was really nervous, actually, lecturing in front of you and your colleagues last year. I was actually really struck how friendly urologists are. And I say that because different doctors are not always as friendly. And you've been to conferences where they're not all urologists and not quite as friendly. But urologists are such a great group. And what I've found about them is that they've got this sort of professional curiosity. They want to ask, they want to challenge, they want to learn. They're not just, and I say just in inverted commas, surgeons. They actually want to learn about the whole person. So it's great that they're talking about it more, but there's still very few people who have recurrent urinary tract infections who are given vaginal hormones to continue in the future. And it's so simplistic, isn't it?
Yeah, totally. And I would add that, when I was passing through the surgical specialties and deciding what to do and going through orthopedics and general surgery and plastic surgery, by far and away, the nicest bosses were the urologist. And that, in the end, that's what made my mind up.
It is important to have good colleagues, because it's not easy, is it?
And mentors.
Yeah, absolutely.
You need someone you want to be like, to aspire to be like. That's what sort of drove me forward.
Well, you've had, especially a couple I can think straight off, but you've had you still have great mentors.
Yeah, someone who's been on your podcast, a few times, Steve Payne.
Yeah, I know. And I've really struggled to find mentors who, who I want to be like. There's bits that I want to be like, but I think maybe it's just the area that I'm in. Maybe it's because I'm a woman, but it is hard finding the right mentor. But when you were doing embarrassing bodies, so we did embarrassing bodies. When I say we, I was just more of an advisor, but you did a lot in embarrassing bodies.
I was the most prolific contributor.
Say that again, sorry.
I was the most prolific contributor.
Which means what, Paul? Just explain.
I had more sections on that show than anyone else.
And why is that?
Because if you're going to think about things which are embarrassing, it's usually the penis, isn't it? So I was doing loads of penis surgery, genital surgery all the time.
Yeah.
And from the second season, because the first season was embarrassing illnesses,
Yeah.
and then it was embarrassing bodies. And for 10 seasons, I was in every single one, often multiple times. It was great. It raised awareness amongst patients. You know, I had people coming to my clinic saying, I saw you on television, I didn't know something could be done for this condition. Because the thing about my area of urology, it's not cancer, it's not quantity of life, it's about quality of life. So there's lots of things that decrease your quality of life. You know, a bent penis making penetration difficult or painful for the partner. You know, if I can correct that for them, you know, they're delighted, their wife is delighted, their partner's, you know. So I did all sorts of operations that improved people's quality of life. And I came forward. And even now, there are repeats on, you know, Dave and Channel 4, and people can find me on YouTube. And they say, oh, I saw you on television.
Well, it's interesting, isn't it? Because I was thinking it was a long time ago now, and social media wasn't such a thing. So it was quite hard to find information. So that programme was really out there, wasn't it? Really just...
I think they should be commended. And
totally.
their website was fantastic as well. And they were, you know, they were one of the first websites to put up pictures of the whole variety of what penises look like, what nipples look like, what breasts look like. So instead of people going to, you know, adult entertainment sites and trying to compare their own penis to something that's absolutely perfect and really long, they could go onto Embarrassing Bodies website and look at all these penises and think, well, I'm just normal.
Yeah.
You know, I'm just normal. You know, I think they did a great job with that program.
Yeah. And you know, people really like the way that you are very direct, but also can be a bit funny as well. The way, you know, surgery, but also the way, like you say, transforming and improving people's lives.
Yeah, totally.
But it does make you think, because even back then do you remember on the studios, people would phone in and I would do some sort of Zoom, like, not consultations, but just conversations. And I was really shocked then, actually, thinking back how hard it was for people to be listened to. So people would say, oh, I've got this rash and I've had it for 7 years and the doctor keeps dismissing me, or I've had migraine and I'm not on any treatment. Just lots of things. And I remember then just thinking, wow, gosh, I don't understand. Like, even as a doctor, if I don't know how to treat, I will always ask someone else's opinion, or I'll try and find out. But these people were just being told they're a bit of a nuisance. And so that was interesting. But also the fact that it was a Zoom, like a remote, because this was all pre-COVID, long time before COVID. So we didn't really do remote consultations then.
No, not at all.
But that's opened and changed the way we practice medicine as well, hasn't it?
Yeah, I mean, for so much of our follow-up, you know, from a hospital perspective, we can deal with it now either through a Zoom-style consultation, although I still don't get them to show the genitalia to me, you know, on Zoom consultations. They will send in photos in advance, which we can then discuss. Or just telephone call, and it makes life much easier, because you don't want to do a 2-hour round trip to then speak to the doctor for 10 minutes, everything's going fine. Yeah. So I think some good things came out of COVID, you know, and those Teams and Zoom meetings we have all the time. Yeah. That's part of it.
Yeah. And I think just the way with Embarrassing Bodies and social media, it's made us as doctors more accessible, and also the knowledge that they have. So I know some of the people that come to see you, they've spoken to other people who have been operated on by you. They know what to expect. They know what you're like. They know about previous results, and that probably didn't happen quite so much in the past, did it?
No, I mean, the younger patients I operate on, who could be, you know, 16, 20, 21, they will go onto forums discussing their problem, and they'll often, you know, have chat with someone who's been dealt with by me. But, you know, you're saying about people living with these problems. Even now, I see people who have problems for decades that never get referred on.
I know.
I think the doctors who just keep patting them on the head and just repeating the same treatment that doesn't really work all that well haven't got a professional curiosity to find out where you could refer on to.
Why is that, do you think?
I don't know. It might just be the amount of workload they're dealing with doesn't give you that sort of chance to think about how you can improve what you're doing. Sometimes you need time at your desk doing nothing to think about how to improve your service and how you can do a better job. But when you're just a hamster in a wheel dealing with so many referrals and so many patients, you just tend to do the same thing over and over.
It's interesting. I mean, I often think about our training, and I think we were really lucky with some of the people that we were trained. We both were in Manchester, obviously, but people really took a long time, like, teaching us how to take a good history, how to really learn from the patients. Do you remember we spent hours, literally hours, and then we went with Professor Maguire down in Withington, who was a psychiatrist who worked with oncologists and tried to talk and not be scared of asking questions. Do you remember?
Yeah, I do.
And even psychiatry, that was really good. You know, if someone's got really poor mental health issues or they've got dark thoughts, how to really ask those questions and not be scared. I mean, looking back, that was quite unique, I think.
It's hard because I've stayed much more narrow than you. But I do remember my psychiatric attachment as being fascinating. I learned a lot. It makes you much better at asking questions, getting that information from patients. But I've got very little else to compare it to because I've not used it. Well, I've not gone down that route for the rest of my career.
No, but if you compare, like sometimes I hear you and you've made a diagnosis, you made a diagnosis of endometriosis not that long ago, somebody who had it in their urethra. And you were saying it's so obvious. And I said, but how? You never see people with endometriosis. And you were saying, well, it's obvious when you take the history because it changes throughout her cycle. Yeah. But you think that's really obvious to ask about a period and if symptoms are changing with a period. But I tell you what, most doctors don't ask at all.
Yeah, but you're trying to change that, aren't you?
I am, you're right. But thinking about, you know, PMS, premenstrual syndrome, PMDD, premenstrual dysphoric disorder, you know, we see people with these awful mental health symptoms and they've been on these psychiatric medications and no one has said, does your mood change with your cycle? It's really not hard. But because we've had good training, that's what I mean. I think we just take it that everyone else does the same.
Yeah, I mean, I think one of the most upsetting and some of the most rewarding bits of your practice is dealing with the severe mental health illness that comes along with hormones fluctuating. And I know that you have given up your own time and driven to see patients who've been sectioned to assess them, you know, on a Sunday or on a Saturday. And when you've spoken to them, it's obvious it's related to their hormones. And putting them HRT has really improved them. And then the psychiatrist, who have a body of doctors been really receptive to what you're doing, have then contacted you and thanked you and said, we need to know more about this. Because some of that really refractory depression, suicidal ideation, you know, is related to hormones. And there's been some fairly high profile and tragic stories that you've covered, you know, and will cover in future podcasts. So I think that I know because, you know, I talk to you a lot and you tell me things, but I think that the severe mental health aspects of perimenopause and menopause is just not appreciated.
No, it's not.
And just to go on about hot flushes and you know, rubbish drugs that just deal with hot flushes is just wrong.
It's wrong for women.
Just wrong.
Yeah. Well, in fact, we've just looked at our symptoms of people coming to the clinic. You know, we've got that new symptom questionnaire, and hot flushes isn't even in the top 20. No. So obviously we've got 3 daughters, and we're quite open as a family. I think maybe being medical, nothing phases us at all. We don't judge the children. We're really open in our conversations. But obviously we talk a lot about hormones, don't we?
Yeah, you do. We do.
But you know what? I'm still a bit annoyed. Shall I tell you why?
You're going to.
Because I had symptoms for about 6 months and when I was clearly perimenopausal, age 45. And you didn't recognise them, and neither did I.
I was too busy trying to avoid you.
But, you know, you help the nurses at work now, but you probably didn't then. But you know what? I remember waking up every night dripping in sweat, and I'm not a sweaty person, and I was too scared to wake you up, so I'd get a towel out of the airing cupboard and then lie on the towel. But I thought I had lymphoma.
I just thought it was a phase and hoped it would end.
But it's hard, isn't it? Because how do you know what is related to hormones or not?
Well, looking back, I'm surprised I didn't think about it because, you know, you've spoken about this on the tour. It was Sophie who picked up on it.
I know.
Because there was no doubt that I would no longer wanted to live with you if you carried on like that. But then that would be really hard for the family. So I can see why families break up.
Yeah.
You know.
I remember that argument in London.
Yeah.
If our relationship wasn't so strong, you would have left me, I would have left you, and I'd be broken without you because you propped me up more than you realise. But like, it's really sad actually because so many relationships break up. And they don't
And you can
have,
see exactly why
yeah.
it happens. Exactly
Yeah.
why it happens.
But it shouldn't, should it?
No. Well, I suppose that's why you've got to also educate the wives, the husbands, or the partners of the women who are going through menopause and
children
perimenopausal.
as well.
Yeah, and the children, because like I say, it was Sophie who picked up on the fact that you were actually perimenopausal.
But it scares me because I love our children so much, but then I didn't love anything, and so many women are bringing up children in homes without love because they don't have the right hormones. But again, it's not being picked up. It's been blamed on their circumstances or mental health or whatever else. And, we see it in the children when they've got step-parents, maybe stepmothers who aren't being nice, and then they thank me after they're feeling better. But the children thank me because they go to the people's houses and they say it's just so much calmer. It just feels so wrong when there's such an easy solution.
But you've got to think of it first.
Yeah.
And oftentimes these people might be in situations which you can't fix, and one component of the problem of the hormones. But if you don't try and fix that one component, it's a shame. It's a shame.
So the good thing is that I take hormones and we're very happily
thank
married.
God.
But I don't think other areas, like in urology, they don't challenge in the same way. They embrace new operations or new treatments, don't they, and try them.
Totally.
I don't know why. Is it because it's women, or is it because it's that area of medicine that's so still misunderstood by so many people?
I don't know. Like I said earlier, and you've mentioned as well, I think urologists are a friendlier than average group of surgeons who look out for each other and want to see everyone, do well and bring them on. At the conferences, we're not really cutting people down to size or criticising a lot. Someone presents something interesting, we think, oh, I'll try that, I'll look into that.
Which is great, isn't it?
Rather than trying to think, well, no, they're getting too big for their boots, we need to see them, cut down to size.
Now, we're not getting any younger, and when the girls were younger, I spent a lot of time working part-time to really look after them, and now my work's really increased, and you very kindly are doing a lot more. But you're super busy. You do a lot NHS, a little bit private, you do a lot abroad, you do a lot of teaching, and when you go abroad, sometimes it's showcase operating where people will watch what you do. Are you thinking about retiring?
No. Jesus, no. Not at all. Don't have to prize the scalpel from my cold, dead hands.
I mean, we're really lucky, aren't we, to have jobs that we enjoy.
If you've got a job that you love, you don't work for the rest of your life, do you, or whatever the saying is. So, yes, I still really enjoy my job. I'd like to shave off, maybe half a day during the week or something. But, no, I just don't see myself stopping. I don't want to be one of these really old surgeons who's a bit doddery and they say, oh, he's past his prime and don't get operated on by Mr. Anderson anymore. He used to be great 10 years ago. So I've got to listen to my younger peers and look at my outcomes.
Yeah, absolutely.
But, if I'm not going to spend time with the family or going out with friends, then choice number 3 for me to pass the time of day would just be operating.
And where you work in NHS is such a wonderful place in the Black Country. The nurses mostly are just incredible. Like, all the staff are, Joe, everyone is just brilliant. But you've worked there for quite a few years and you have watched them change, some of them, when they've had hormonal changes, haven't you? You've seen the differences.
Totally.
But you've helped them, haven't you?
Yeah, we've had conversations, whilst operating, just talking about, if they're clearly not what they used to be, if they're not quite as sharp or as good as they were, and you ask them, what's going on. And it's just that time of life. And then having a conversation about HRT, because they all know that I'm married to you, getting them to download your app, and then maybe, talking to them again. And then for some of them, as you've had, chats with them. And it's been, transformational is the word, isn't it? They've gone back to being much more their normal self again. But there is loads of scaremongering. I would say to one of the nurses, I think she'd be on HRT, they're just worried about breast cancer straight away. And it's absolute rubbish.
No.
We know that million women study was completely flawed. And there's been a fantastic, dissection of it by that Professor Gynae from Washington who came over.
Jim
He gives a great lecture. And it's disgusting how it just set women's health back.
Well, the Million Women Study and the Women's, the WHI, the Women's Health Initiative study, both of them, terrible. But it's been amazing because you've really helped those people. And I like to think if I hadn't done that work, well, I wouldn't like to think because you wouldn't have helped them. But this is where like the conversations can't just be about women who are suffering. It has to be people in work, men as well as women, because you're very frank and outspoken and the nurses know you for that. So actually for you to tell them in a non-judgmental way that you're changing, could it be your hormones?
No, you just need HRT.
Yeah, but they're grateful for you, aren't they? Sometimes.
Yeah, most of the time, yeah.
But who else is going to talk to them like that?
Yeah, good point.
And I'm sure you can see people are leaving, taking time off, not...
Well, they're wanting, often the classic thing is they want to reduce their hours.
Yeah. But how can the NHS...
But it's difficult to reduce your hours because if a nurse wants to shave 10 hours off a working week, you can't employ someone for 10 hours to backfill.
Yeah.
So it's very difficult for them. It either goes to, I've had these chats with them.
Yeah. So we need to keep going and keep helping people. So 3 take-home tips I always ask for. I'm just keen to ask 3 things that you think going forwards is going to make the biggest difference to women, actually. Knowing what I do and knowing sometimes the battles that I have, blockages that I have for the work that is detrimental to women, what 3 things do you think is going to make the biggest difference to women's health going forwards?
I think you've got to keep on putting out that message that HRT does not cause breast cancer, and that actually in those studies, pure estrogen, proper estradiol, actually reduced your incidence of breast cancer, because no one knows that. So if people weren't so scared of HRT, they'd take it, more easily. The other thing is that, with dosing of HRT, and again, I completely agree with you because I see this in dosing of testosterone as well, that some people just need more than the recommended guideline, and it's just a bloody guideline. It's not the law, it's not the rule. If people need more patches than another group decrees, you're not doing anything wrong, especially when you back it up with blood levels. So people shouldn't be afraid of having more than 100 micrograms. And finally, just to make people think about hormones, not just in the context of psychiatric illness, where I think it can be most disastrous if it's missed, but just in terms of general health. I'm always thinking of it in terms of UTI, urinary tract infections, with genitourinary syndrome in the menopause. Now I think I'm even better, because when I see the older ladies who've got fragility fractures, that's osteoporotic fractures, I'm thinking, are you on HRT? Why aren't you on HRT? But I think if all doctors start to think, could hormones play a role in this person's illness, then that would be fantastic.
Wouldn't that be nice? Then I might retire. Thank you very much for joining me today, Paul.
It's been a pleasure.
I've enjoyed it.
See you in 4 years.
Subscribe to my newsletter for exclusive insights and updates on new episodes.